All right, so we're going to be covering joints. I know we're going to redo that second bone packet, but there's only 2 topics really to discuss on it, and joints will be a little bit easier on us since we had a tough lab today. And so when we look at our joints, keep in mind that now we've been using this word occasionally, articulations, because this word means where 2 bones meet together. They meet together. That's what articulation means. And when we consider a joint, this would allows for mobility, but what you're going to see in a second is that sometimes a lot of joints aren't necessarily mobile. Like, for example, one that's pretty obvious to us is going to be something like our tooth inside its socket, right? There's not a lot of mobility on it, so you would never really consider it a joint, but it is considered a joint, and it's not really meant to move. Another one is the costal cartilages, right, that we learned that are made out of hyaline cartilage. They're not meant to move, but they are still considered a joint. And so some are more obvious, like this is going to be like an example of an elbow joint, a knee joint, a shoulder joint. They all have the same little capability, and they have much more mobility. But so that allows us to give it some sort of nomenclature or organization when we discuss. We can actually categorize them by how much movement they allow. But otherwise, a joint is typically when one bone meets another, and we consider that there's a possibility of movement. And that movement is considered range of motion. When things are moving appropriately, they're moving in an appropriate range of motion. We've heard of the word dislocation, or we've seen that sometimes the humerus will pop out of the scapula, out of that glenoid cavity, and that's because sometimes it went at an angle or a range of motion that's not normal, and it can pop out of its joints. So we consider a right amount of movement that every joint has as its range of motion, and leaving that range of motion can cause a dislocation, as we're going to see a little bit later down the line. And so now, when we look at this functional classification, I like to call it the SAD scale. And SAD scale, the S and the A and the D, are coming from the S and the A and the D of these terms here. Synarthrosis, amphiarthrosis, and diarthrosis. And we are talking about joints, so some of this might sound familiar, like when we say arthritis, right? And so this is going to be what we're talking about. Usually it's a reference around the joint. So syn, usually in Latin, means together. Amphi means on both sides, and di means through. And those don't really help you learn what they are, but it's easy just to think about it when you think about a little scale. And I'm going to go ahead and try and draw this for you. That when we look at synarthrosis and amphiarthrosis on our table, these same terms, what we're really trying to describe is how much mobility something has. So if we draw our arrow, I'm going to use the little tool here. When you draw all the way down, right, and you get a little, like a line this way, and you draw your arrow this way, that's the amount of mobility that these have, with this being the most movement or no movement being on this spectrum of the arrow. And then on this spectrum, as we travel in this direction, we have much more movement. Okay, there's much more movement. The labels are there already for you. So free movement here. And so if you want to make it even more simpler, you can consider this as immobile and very mobile. And here with little movement, I think that's self-explanatory, like slightly mobile, right? Almost the same meaning. And so whenever you classify joints, you can always classify them along the SAD scale. You're either calling them synarthrosis, you're calling them amphiarthrosis, or diarthrosis. And a functional category is literally answering or telling a person how much movement does this joint have. So synarthrosis is considered immobile, and diarthrosis are the freely mobile ones. So some example of these, they are sutures. These are going to be, we're going to explore these when we go into our skull next week, and you're going to see that some bones, like for example, this is our occipital bone, and this one over here is our parietal. This is another parietal, and the skull itself is not like just one piece. It's not like a helmet, like a football helmet. It's a multiple amount of pieces of bones that come together and join together and form a joint. So every little crack you're seeing here, it looks like stitching, like someone stitched it together. Last week, or Tuesday, we learned about sutural bones, and they're named that very same thing. So those are sutures. And this makes sense, right? These are clearly going to be classified as synarthrosis because we don't really move our skull bones, right? They're not moving around and shifting. So this is what we mean by synarthrosis, is we classify these joints because there's still a joint because it's one bone meeting another, but it's not very mobile. And so we consider the ones that you find in your skull as sutures. Gomphosis is going to be the name of a tooth inside of its socket. And so again, these are not meant to be that mobile. I know that some of us might have had braces or have braces, and or sometimes feel some movement along your teeth throughout your lifetime. And technically there can be some shift with aging, but the joint itself is called gomphosis. Now, what is the difference between these two tables here? Like, what is the difference is this is the name of the joint, the structural category. And because they're made out of different things that you are aware of. Like you've learned about fibrous. This was an example of like dense regular connective tissue. And then cartilaginous has nothing to do with dense regular because dense regular had to do with cells that made it, usually were fibrocytes or fibroblasts. And cartilaginous joints don't care about fibrocytes. They care about what cells? Chondrocytes. And so their joints, they're immobile, and they have the same properties as, say, the fibrous ones, but the difference is the material that they're made out of is different. So when we say structural classification, we're really attributing to it what actually makes them adhere or glue together, to speak simply. And so chondrocytes are just the ones that make up anything that's cartilaginous. This one I'm going to ask you to cross it off because I feel like it's so rare and probably something I can bring back during reproductive because it only is really something you see in infants. And so when we get to reproduction, we'll probably bring this one back, but otherwise you can get rid of it. Synostosis. You can just cross out, pretend it doesn't exist. And so that's the main difference between these two. But if you were to classify their functions, they are all S on our SAD scale. They are synarthrotic, meaning that they aren't meant to be moving around. So know these very examples. And just in case you didn't catch this, this is an example of your costal cartilage, which we explore in lab next week because it's part of the axial skeleton. And gomphosis, again, would just be its tooth in its socket. And then a suture is a joint between, I'm going to shorthand this, between the flat bones of the skull. This next one, amphiarthrosis, is going to mean slightly mobile. So we can describe these joints that we find in our body. We learned about these this week. We saw this one. I know that this is a little hard to make out, but this is sort of a bent olecranon right here. This is the back of your ulna, and this is the humerus. And they're sort of showing you a little bit flex, a little hard to make out, but we'll see another picture of it a little bit later down the line. And so you can see the joints that keep them together are going to be made out of fibrous, or they're going to be made by fibrocytes. Same concept. It's just that they're made out of different cells. The fibrocytes make this. And once more, our cartilaginous ones are going to be made by our chondrocytes. Go ahead and open it up. And so when you look at, for example, this allows for some mobility, right? This allows for a little bit, but they're not really meant to be that mobile. Sometimes they're more stabilizing. We'll see an exact example of that in a second. But otherwise, nothing really changes. And we designate this as syndesmosis. And I'll provide a better picture for you in a second. And when we look at cartilaginous, an example of this one here is going to be the pubic symphysis that we learned about in lab this week, where we saw that this is going to be the coxal bone, the one that, this is where the femur bone would be anchored in that socket called the acetabellum. And so this is one of them. And so where they meet, it's made out of a little bit of fibrocartilage. And fibrocartilage is made out of chondrocytes. All cartilage is made out of chondrocytes. And so we designate this one as syndesmosis when it's made out of, we'll see an example of it in a second. And cartilaginous, this one's an easier one. Anything that's made out of cartilage, always going to be chondrocytes, called the symphyses. Now, synovial is the easiest one to understand and the most frustrating one to learn. But when you look at synovials, these are always going to be diarthrotic. You're going to have a lot of joints in the body that have a lot more mobility, because if we compare, for example, a tooth joint to, say, a joint like that's on your shoulder, right? There's just no comparison. This has an insane amount of mobility compared to the tooth joint. And so you would classify this one as diarthrotic because it means that it has a larger range of motion compared to the other ones. And so a synovial joint will be its own topic, as we're going to see in a second. And so synovial joint, they have a theme, that there's always a capsule. We've learned that the cartilage at the end of bones is called articular cartilage because it's preventing wear and tear throughout your lifetime between the bones. And there's also a cavity in here with fluid, giving it some compression strength, which we're going to see in a second. So every synovial joint is going to be diarthrotic, and we'll see an example in lecture in a second. And again, cross off this, and everything that I mentioned is just here in text for you, but there was one thing I did want to mention. Which I suppose I'll have to actually show you both all in lab next week when we get to the ribs. So what we're going to do is we're going to put a little asterisk on this, right here on synchondrosis. And I'll show you in lab next week with some better visuals, because I don't think I actually put one in here, which is kind of lame. But I will bring that up in lab next week. Yeah, I didn't even place it here, but okay, we'll deal with it next week. And so the star of the show for joints becomes the synovial joint, because there's a lot more going on. The other ones are sort of synonymous to, they're just stuck together slightly with connective, and they either move a little bit or they don't move at all, and they are glued together by either fibrous tissue or cartilage. But synovial joints have a little bit of both fibrocytes, creating something, and also the chondrocytes, and they're much more complex. Just using this picture here, this is the theme of these joints. We have some in our mandibular, the one that holds the mandible to our skull. We have the one that makes our elbow joint, the one that we saw that makes the humerus bone. And then we have our two bones on thumb side. We have our radius and our ulna. So within here, there's this little capsule providing some movement, and more precisely, here, this is going to be our easier one. You encounter these themes in synovial joints, meaning they all have some component, they have these components. And so articular cartilage, this one's one we explored last week when we looked at long bones. Again, it's going to be a little bit of cartilage that's located on the very ends of bones to prevent degradation between each other. The joint capsule is going to be what actually creates an encasement between the bones. And inside of that encasement, if we zoom in, you'll see that there's this inner membrane here that creates our synovial fluid, which is going to be a fluid that is in this space. And I wish I had a water bottle to provide sort of a quick function of what synovial fluid does. Right here, synovial fluid. And it's a fluid within the joints that is lubricating the joints with each other, and also provides a little bit of compression strength, which I'll try to illustrate with a bottle in a second. And then that inside where the synovial fluid is flowing is called a joint cavity. And so all synovial joints contain these properties or these components. So that's where you really want to start, is you want to actually be able to learn these components of a synovial joint. If we refresh our memory on some things, on bones, right, the very ends, the epiphyses of the bones, they tend to be on the ends and be made up of spongy bone. And the medullary cavity was the space inside, which again has a little inner layer called the endosteum. And then the outer layer, that first thing you see when you look at any bone on the surface, is called periosteum. And so you can see that we have ligaments, and ligaments were made up of dense regular connective tissue made out of fibrocytes, and they are anchored onto the periosteum. The joints themselves, ligaments, this dense regular connective tissue, it adheres or sort of connects or is embedded into the periosteum. You know, when you actually, I don't want to say rip a ligament, because this attachment is so tough that when you actually rip a ligament off, sometimes what happens is that this is so strongly, firmly attached that if you go out of your range of motion during a dislocation, you actually might break off a piece of the bone. That's how strong this attachment is. And so ligament is made out of dense, regular tissue. And don't forget that the outer layers are made out of compact bone, and everything within the epiphyses that looks sort of spongy and hollow is spongy bone. Spongy bone. All right, so this is sort of a recap of what I mentioned, just a little reading to go over the functions of what I've mentioned here. Just read through them. The one I have to discuss is the synovial fluid. Here, when we look at this tends to have a straw colored. If you're not sure what straw means, it's sort of like hay, like what you feed horses, like that brown or brown gold color, straw colored. And it has a consistency or a viscosity, meaning like it resembles egg whites, sort of like a sticky in essence. And you do not need to know that it's hyaluronic acid. Do not need to know. This is just something that fibrocytes require in order to work, but otherwise, just their viscosity is just something you might encounter depending on what field you go into. And the synovial membrane is what produces the synovial fluid within this space, and that's going to be just that inner lining that we see on the lateral ends here, that we see at the ends here. That pink little layer on my screen, I know yours doesn't have color, but that's going to be your synovial membrane producing the synovial fluid. Now, properties of the synovial fluid are what matter. Lubrication is a little bit easier to understand. If it has that little like gooey texture, then it reduces friction between the two bones. Nutrient distribution as well, as it creates these cartilages, these chondrocytes, they require a lot of nutrients, but there's no blood vessels directly embedding in here. I think I've driven the point home by now that whenever the body, what it does to provide nutrients to all its tissues is to innervate blood vessels, but there's not a lot of blood vessels. It's not very vascular in here. There's no blood vessels providing nutrients to your precious chondrocytes here that are maintaining the articular cartilage. Instead, they are embedded here on the ends, and so the synovial membrane, these cells, which are actually squamous cells, but we're not going to get into that detail, they produce the synovial fluid into the space, and they're utilizing all the blood vessels that are within their basal side. And on their apical side, they produce the fluid, and then they allow the nutrients that need to get to these segments. They produce it into the synovial fluid, and then now it allows for a distribution of nutrients, and that's what this fact means, or this statement means. And now shock absorption. Now shock absorption, does anybody have a plastic water bottle by any chance? Nobody? Nothing? That works just fine. And so, like, if we pretend this is like the cheap ear, that we have the cheap ear bottles, right? The ones that you find, that you can just buy at the gas station, that when you look at them, right, if you try to smash it and it's full of water, it's almost impossible. And that's kind of what that compression, shock absorption is meaning, is that if you have fluid, it would be impossible no matter how much weight I put in here. You know, there's a limit, but if you put a little bit of weight on it, you would never be able to smash it if it was full of water. But if it was empty, you can all imagine with enough weight, you can just crush it right down. If it doesn't have that air, because even air itself provides a little bit of filler, right? If it's like full of air, you can't just crush it. But if that air isn't in there, you can technically all imagine that it can just be completely crushed. And so this fluid provides a lot of compression power on a lot of your joints. So that's why someone can do handstands and this won't like just explode or rupture out. Or you can even just stand and hold your own body weight and it won't just like your knees won't just explode on, when you're jumping up and down. It's because you have a little bit of an ability to shock or absorb that shock because of that fluid. So you have to imagine to yourself that this fluid is in that space, providing some shock absorption. So these are 3 very important synovial fluid facts. And now with that, this is the components. That means that no matter what synovial joints you might find large ones, you might find smaller ones, and they all have these components. This is the common components of all synovial joints. Now, what makes synovial joints difficult is that, as you've seen, that the joint even that makes our elbow joint, right, between the radius, the ulna, and the humerus, this looks completely different from when we explored the bones down that make up the femur and the tibia and the fibula. You can see that their meeting is the way they meet is entirely different. And so they have different components to them depending on the need. And so some of them are going to be our bursa. Now, bursa is sort of like when we thought about a joint cavity, right? That whole entire space in here that contains synovial fluid. What bursa are, they're like little mini cavities, little mini sacs. And the good news is all they possess is synovial fluid. They possess it in like little bags that just sort of help cushion the actual joint itself when necessary. You can even see it's even in the front of the patella. You've all might have like fallen and hitting your knee and it hurts. And it would be worse if we didn't have little bursa, little protective sacs protecting that very precious patella in front of the femur and the tibia. And, oops, wrong thing. And so, another one that's pretty easy, all this yellow that we're seeing, you can see that fat is also used, our adipose cells, adipocytes that produce the connective tissue adipose. They are also there filling in the spaces between our skeletal muscle, which is very voluntary. This is the muscle that you use to bend your knee, right? If we're looking at the femur, we're looking at the tibia. We have a lot of muscles around to support the range of motion or even cause the motion, but also to make sure that things don't break their range of motion. And so you can see that fat plays a big role in cushioning and filling in that space, and even provides some more shock absorption if when you're jumping up and down, that downward pressure, so that way it doesn't just explode on you. So fat pads are another form of compression or providing compression shock. And not just that, there's a little available energy source. We know that this little pink inner lining here was our synovial membrane producing our synovial fluid, and that requires nutrients, and fat is the perfect storage of nutrient molecules like lipids, right? Or lipids. Next, we have meniscus. Now, there is a difference, and I know that it might be a little tough to go back, so we're going to take a moment because this is a shorter lecture. And if we go back to our tissues, I know that some of you are going to get a little scared. But if you recall, cartilages, it didn't matter which one was which, they are all going to be made out from chondrocytes. Chondrocytes in lacuna, chondrocytes in lacuna, chondrocytes in lacuna. But when we explore dense regular tissue, on our exam, we know that they are found in tendons and ligaments. Tendons and ligaments. So there is a difference in some of these structures that we're seeing, in that when we look at tendons, they are made out of fibrocytes, not chondrocytes and lacuna, but fibroblasts, fibrocytes, and they make up your ligaments. And so when we go to, wrong one, I lost it. And so we have to sort of draw a distinction here that although they're sort of sharing the same color, that when we say articular cartilage, we are made out of cartilage, out of chondrocytes. These ligaments, when you hear the word ligaments, they are made out, and tendons, they are made out of fibrocytes. Now, this is a perfect example to see what's the difference between a tendon and a ligament. They are made by the same cells, but they're a little different. Here we can see a skeletal muscle with all its striations. It's also has a multinucleated, it's voluntary, but how does it anchor and attach? You'll see that it anchors and it uses dense, regular connective tissue to stay anchored into bones. And even though it's not showing it here, this one would also probably be anchored by a white little fibrous connective, dense connective tissue here. It would also be anchored onto the bone here. And when we compare it to a ligament is different from a tendon because a tendon is responsible to anchor a muscle to bone. Muscle to bone. And so it anchors muscle to bone. If we look at a ligament on this end, you can see that the ligament travels from one bone to another bone. So a ligament anchors a bone to a bone. And that's all the difference between a tendon and a ligament is, but they're made by the same fibrocytes, the same fibroblasts. And so here once more, remember, articular cartilage made by chondrocytes, anything called a tendon or a ligament made by fibrocytes. And so with that, our meniscus, and we're going to see meniscus and ligaments, these are all going to be made out of our different materials. And I'm just going to keep it simple right now. And let me just see if I wrote it here. Yes, I did. And so when we look at our meniscus, you want to keep in mind that our meniscus is made out of chondrocytes, so it is a cartilage. Oops, wrong thing. It's kind of already written there for you, but still just want to, or I'll just highlight it here. Right, so even our meniscus, aside also from this articular cartilage, is also made out of chondrocytes or cartilage. And ligaments is not. It's fibrous or made by fibrocytes. This means the same as above. The same as above. All right, so let's see. Bursa, fat pads, meniscus, and now our ligaments. So when we examine our ligaments now, you'll see that there are patellar ligaments and cruciate ligaments. This is a good one to explore, extrinsic or an intrinsic ligaments. And what that means is outer and inner. So extrinsic means outer, and we're going to see examples of them in a second. But otherwise, these are going to be on the outside of the joint. And when we say intracapsular, remember that this is coming from the fact that every synovial joint has a joint cavity, which is interchangeable with capsule. And so you can see that a patellar ligament, I'm going to go ahead and erase this. You might need to write something else nearby. But patellar would be considered extrinsic, meaning on the outside, and cruciate, in this case, and in most cases, typically implies within or intrinsic. But within is easier, right? Within capsule. Within the capsule. And using our diagram, if we were to draw just some generalities around it, you can see this ligament here. This is on the outskirts, right? On the outside. All of these are on the outside. They never cross right through. They never cross through. But a cruciate ligament absolutely does. So it goes from one end to the other and one end through this way. So that's why we call them intracapsular, because they go through the capsule. They pass inside the joint capsule. And so an example of this is the cruciate ligament. And we're going to see the knee is the one that we use to understand synovial. There's about 9 or 8, but for our lecture exam, we only really learn one, and that's going to be the one around the knee. And we're going to see a little more detailed pictures in a sec. And so this is our knee joint now. These bones will sound very familiar today, right? We have our femur bone, which is going to be proximal, and as we go more distal along the limb, we have our tibia on the medial end, and we have our fibula. And just keep in mind, the front of it had this tiny little large guitar pick looking bone called the patella that sits right on the front, right on the anterior portion of the joint. And then the back end was called the popliteal. And so if we examine just the knee joint, we're going to see some of these properties that resemble the accessory ones and the synovial. So I like to just stay around the knee joint because it's a popular one, because we're all going to have knee pain at some point, so it's kind of important to understand it. So let's get organized here. Okay. And so if we look at these joints, some of you may have heard of ACL, right? The anterior cruciate ligament. This is a popular one that's discussed in sports because someone hurt their ACL. And it's basically named after something that we already discussed. Our cruciate ligament, we have another cruciate ligament. We have one that is anterior and one that is posterior. If we look at our knee joint, this patella is in the way of our visual, right? We have a ligament called the patellar ligament, which is an extrinsic ligament, just like before. That's why I like using this picture, because it's already on the same joint. But you can see patellar ligament is on the outside, and it's also considered extrinsic because it is not going through or crossing through the joint capsule. So this one by itself, on its own, is really easy to understand. It's an extrinsic one on the outside. Why is this one, why can we not consider this one an extrinsic ligament, even though it's made out of the same thing? And try to use this as a clue. Why? Because it's not a ligament, it's a tendon. That means that there's a muscle above, what you know as your quadricep, that there's actually no attachment from bone to bone from the patella on the superior portion of the patella, right? We're seeing a muscle connected to it. We are not seeing a bone-to-bone connection. We are seeing a bone-to-muscle connection. But if we look at the inferior aspect of our patella, we can see that we have a bone-to-bone. So this is a true ligament or a ligament. And again, extrinsic because this ligament has nothing to do with crossing through that capsule. And so with that, if we look at this portion here, you can see we have our patellar ligament that is completely extrinsic. So that's the first example that we have an extrinsic ligament. But still staying on what I think is a little bit more tougher is the anterior cruciate ligament crosses through the joint capsule, and so does the posterior cruciate ligament. And so if we examine the same knee joint, and what we're seeing here is that we are removing the kneecap, the patella. We removed it, and we can even see that the patellar surface of the femur is there, and this is where the actual patella would sit. So if we remove it, we can see the inside of our joint. And so what we are looking at when we look at just the anterior aspect of the joint after we remove the patella is that, again, we are anterior and a little deeper now because we removed the patella, is that you can see that the one that comes first, right, the one that's closest to the anterior portion is referred to as the anterior cruciate ligament. And it cruciates, sort of like crossing through, right? That's kind of what the word can remind you of, crossing through. And it starts at the tibia, the anterior portion, and travels through the joint capsule and attaches to the back of the popliteal area of that femur bone. And the posterior cruciate ligament originates on the posterior portion, crosses through the joint capsule, and then attaches to the anterior portion. And all you're really adding is, where does it start? Does it start in the anterior portion or the posterior portion. And both of these would be classified as, once more, cruciate ligaments because they travel through the bone itself. And that type of anchoring locks the knee in an extended position. Now, what does that mean? At the end of this lecture, what we really just finished on today is the concept of extension. And when you think about extension, you are thinking about the knee being straight. Like you can all imagine that right now, even as you straighten out your knee, they can't go further than that, right? Like your toes, like right now, if I put my knee up, I can't make my toes touch my face, right? It doesn't work that way. And so it locks it into place. Oh, that kind of hurt. When you locked it into place, and so when you lock it into place, that's the limit. And what's doing that for you? The cruciate ligaments. It locks it. And you can all imagine that right now, if like I put my leg up here and one of you just freaking sat on it, you can all imagine it's just going to dislocate that joint entirely. And it's not meant to move that way. And that's because you're going to rip my cruciate ligament. And so when you go, if we examine the range of motion of this bone too, this is called flexion, as we're going to see in a second, and this is called extension. And so this is its range of motion, is that it does extension and then flexion. That's its range of motion. But again, we go back to that example and someone just sits here, that's not its normal range of motion for this to just dip down like that. And so it's going beyond its range of motion. And so the cruciate ligament, as we see on our notes here, locks the knee in an extended position so that it doesn't go beyond its range of motion. And just assume that they both do the same. Oh, sorry. And so just imagine to yourself that we have that same, that both of these are responsible for that very thing. Now, menisci, made out of fibrocartilage. And what I love about this is that menisci is not that much more different from what you already know. When we explored fibrocartilage, the main example we have you all learn is that it's found between the intervertebral discs in the vertebral column, as we're going to explore a little more in detail in lab next week. And each one of those serves as a little pillow pad between the bones. So one bone and another bone, that little cushioning is created by fibrocartilage, like little pillow pads. And so the menisci, the great thing is that since they're also made of fibrocartilage, they have the same exact function. It acts as a cushion, and then they also do provide a little stability, and let me explain with our image. Is that your menisci is going to be this little pillow pad, and you can see that there's a little bit of elevation here on this end, a little bit of elevation, and that sort of allows for this little, this little indentation. It's not really that prominent on this one, but you can sort of see that this fits nice and snug into that menisci. So it does sort of prevent the bones from sort of going too far in that motion. But menisci for us, medial and lateral based off of the name. And we learned about our medial condyles this week. We learned about our lateral condyle. The medial condyle would be underneath the head of the femur, right? The head of the femur, medial, because that's where it sockets. And the lateral is going to be on top of the fibula. That's even easier, right? The tibia is always medial. The fibula is always lateral. So all you need to do is find your fibula. You know the fibula is lateral. So this is your lateral menisci. And this one is your medial. Your medial. The one right directly on the medial side of the tibia, right? This is our tibia bone. And recall that our femur is always in contact with only the tibia. The fibula is always hiding. It doesn't want to do any work. So it hides underneath the tibia. And so the medial is on this side. The lateral one is underneath the lateral condyle of the femur. Now, these are much more easier to learn. When we look at the word collateral, you want to think to yourself, outside. We already know that anything that isn't called, if it's called cruciate, we know it crosses through. But anything that's collateral is going to be on the outside of the joint capsule. So some easier ones before we get into don't let these names intimidate you. You can already figure it out now with your bone knowledge. Lateral collateral ligament and the medial collateral ligament. All you have to do is imagine to yourself which side is lateral and which side is tibial. So if we look at our fibula, you can see that our fibular collateral ligament is literally telling you that it's on the outside of the capsule, and it's telling you it's on the fibula. So this is interchangeable with lateral. And then we know that the tibia, that's going to be on the medial side, so this is interchangeable with medial. So sometimes you'll see both, and both are important to learn because you will see both. And just as simply, their functions are exactly what the word tells you. It provides stability on the lateral side. This one provides stability on the medial side. Nothing more to learn there. And the last one, and the popliteal is found on the posterior side. And so you need a ligament that runs on the outside, supporting on the outside. So you can see that the outer ligament, an extrinsic ligament, is going to be called the popliteal. So this viewpoint here that you're seeing is going to be posterior. It's just not there. I thought it was there. I was going to highlight it, but posterior. And so you can see that popliteal ligament would only be visible on the outside of the joint capsule, and it's called our popliteal ligament. Keep in mind that the fibula is not part of this knee joint because it has absolutely nothing to do or no direct contact with the femur. And that's all there really is to it. So be able to label this picture. All right, if I provide this picture, either one of these three, and I give you a word bank, you should be able to fill all these terms in bold in. Okay, I would write that as a little asterisk to the top. Think of it to yourself as labeling test question. And no, just knowing the small nuances, like just does it go through the capsule or is it on the outside, is important. So, and I would say like the function, and to keep it light. I promise I won't go too crazy on this. Function, just one statement that you can draw out of this, each one of these underneath the umbrella or under the bolded terms will be just fine. And this is the only synovial joint we explore. I like to show you more in lab, just to show you the difference when we sort of review in lab a little bit around synovial joints, and just to show you what you might encounter if some of you go into some sort of therapy. What's the word? Why am I drawing a blank? Physical therapy. Then you can I can show you just examples of like what's the difference, because believe it or not, your mandible has the same build as, or the same parts of these, but it looks so different. It's just so interesting to see how we classify our mandible as a synovial joint, because we can actually move that joint, right? We can do this, like we can protrude it, we can bring it, retract it, we can rotate it ever so slightly, and then we can go elevate and depress. And so it has a diarthrotic motion or ability to move. Diarthrotic ability to move. They're free moving. And it's just so odd to see how little and tiny it is. And so we stay on our knee joint here. And so what would we classify as a knee dislocation? When the joint itself, right, or the muscles or the ligaments fail to stabilize and they fail to maintain the range of motion, or maybe some blunt trauma like our little knee bar example here, like if someone sat on my knee, you will pop or rip your tendons apart. And dislocation is not the same thing as a fracture. Dislocation implies that the bones are no longer in their appropriate orientation. This is sometimes referred to as luxation. Luxation. If not, that's like the same exact word, pardon. And when we bring it back to the beginning, right? Synarthrosis on our SAD scale. Remember that SAD? We had our SAD scale with D being the most mobile. Most mobile. And this one being the least. You can see that synarthrosis, this explanation that you don't really have encounters where the synarthrotic joints, like the ones that are in our sutures or the ones that make up our tooth, they're not necessarily being ever really in danger of being dislocated because they have rarely any range of motion. And the diarthrotic ones, these are the most mobile and therefore the weakest. And so this same flow chart can actually function like this. You can actually even think to yourself like this: weakest and strongest. And because they're capable of moving much more, they are the most mobile, that makes them more in danger of dislocation or luxation. And so the strongest have the least amount of movement, and so they have the least danger, or they're in the least danger of dislocating. And the proper definition of a dislocation is movement beyond the normal range of motion. And even the rest of it is very easy to understand. If we know what the word articulating surface means, it means where the bone surfaces that meet together, and so they're forced out of position. This is caused by damage of joint structures. This could be because you had such a like some heavy body lifters can put too much downward compression, and that synovial fluid will just put pressure and explode the capsule outwards, or it'll just rip one ligament. Isn't enough to rip the whole capsule. And so the joint structures that we're talking about here are the components of synovial joints. And the last thing to add here, just like before, we mentioned that we rely on our synovial fluid to provide a lot of nutrients to our joint capsule, right? This, let me use this one. If we look at this once more, remember that our synovial fluid in here, this blood vessels aren't just innervating in here. They are all these tissues, these articular cartilages, are receiving all their nutrients from the synovial fluid created by the synovial membrane. So we don't have vascularity in there. We also don't have nerves in here. We don't actually feel this in pain, but we do have nerves monitoring this space here, like in the ligaments. And that's all that last little statement on that really means, is that we don't actually have nerves inside of the capsule. The nerves exist on the outskirts where the ligament is. And so that's why no pain receptors. So when you feel pain, and that's what the principal dislocation, it's occurring at the ligaments that are ripping or are tearing, or just really depends on the type of injury. But otherwise, tearing out of their attachment. And so the fun part, and sort of the light and easy part now, is motions. And this is where your homework's going to be, is that you really want to learn these motions. When we go into muscles, you're going to see these words being tested in lab. And so learning them now is so much more beneficial. And so let's use it with pictures. So flexion always implies making angles smaller. So I kind of want you all to sort of have your hands out like this, right? Hands out like this. You don't need to take any more notes. It'll be pretty easy. Here, when you think about your fingers, flexion means to make this angle. So when I say flex your fingers, what do? This. If I say flex your wrists, what do? This. If I say extend your wrist, what do? This. If I say hyperextend it, like this, right? So, and then I want you to extend it one more time. And then I want you to extend your fingers. What does that look like? Good. Can you hyperextend your fingers? Not really. It's really hard to really get that really negative like movement there. So if you hyperextend a finger, you dislocate it. Okay, that's an example of how some terms can apply to some joints and others can't. Another one, elbows. How do we flex our elbows? We go up. How do we extend them? Nice. So that's why, like when you flex at the beach, that's where the word comes from. Flex at the beach, right? Try to use that to remember. When you flex at the beach, it means making that angle smaller. And then if we want to flex this joint at the shoulder, what does that look like? That one's a little tough. Yes, exactly. Flexion. And if we extend it, all the way down. And now what would it look like if I said I want to hyperextend this one? What would it look like? Right? All the way to hyperextension. And if I told you to hyperextend your elbow, could you do that? You cannot, right? If someone like did this, right, like we all seen arm bars or MMA or something, right? Like if this break, like they put enough pressure this way, it's gonna dislocate your joint there. And so it's really easy to understand flexion and extension. They're the easy, my favorite ones to start with. And then you can also do it with your neck. What does flexion of your neck look like? Yes, flexion of your neck is like this. What about extension? Back up. And what about hyperextension? Straight up. Awesome. And now with our leg, if you think about your leg, I'll do this one. You have 3 points, just like, 4 points, right? You have 4 points. 1, 2, 3, 4 on the limb, right? 1 being the shoulder, then the elbow, then the wrist, and then the fingers. 4 points of flexion. If you think about the leg, you have the same 4. You have the thigh. I know you're all sitting, so you can't do this one. So flexion would be upwards. Extension would be bringing it right back down. And can we hyperextend this one? Yes. Yes, we can, right? We bring it to the back. And so with that, 4 points of flexion, just relying on our image here, because I know some of you won't be able to see my knee. But if you bend the knee, right, if we oh, wait, that's not the right picture. Oh, there is no picture for it. Okay, I guess I'll have to do it. So when we do the extension, again, extension is straightening it out, and flexion is bending this. Flexion, 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 and it has the same properties as our elbow. Elbow flexes, extend, and it doesn't have hyperextension. Same with this one. It flexes and then extends, but it cannot hyperextend. And so that's the second point. So point 1, point 2, and now if we think about our wrist or the ankle, which is the same one as this one, it's a little different. It's a little different. And so we're going to rely on this image here for this one. When we look at our flexion around this joint, right, like this is sort of synonymous or similar or partnered up with our carpal joint, right? Like this is it has the flexion, it has extension, and then hyperextension. So there's a little bit of range of motion, but we change the wording for the lower limb. Instead of flexion and extension, we actually use dorsiflexion and plantar flexion, which are really easy to remember because the bottom of the foot was called what? Plantar. What was this heel called? Calcaneal, right? And then the bone is called calcaneus. And so this is the plantar region. So if you go downwards, like you're driving and you press the gas, it's going to be plantar flexion, flexing towards the plantar region. And then if you go upwards, letting go of that gas, then it's going to be dorsiflexion. And the way to remember this one is that dorsum is the back of your hand, even your hand and also your foot. The knuckle part of your hand is called a dorsum. And the top part, like if you're throwing a karate kick and you're going to kick somebody, right, you kick them with this part where the laces are, and that's called your dorsum. So when you go in that direction, dorsiflexion, dorsiflexion. We also have lateral flexion, which is a little bit easier to understand. You have it on your neck, right, going lateral, lateral. And then you can also do it with your vertebral column, right, like lateral, and then lateral. But we'll discuss that when we get into, we'll see it more on the vertebral column with muscles, and we'll learn that a little bit later.
Professor,
Ask away.
I had a question about like people that are like double jointed. It gives off the, I don't know if it is hyperextended, but it gives off the illusion of hyperextension.
So my understanding of double jointing is when when you've seen someone being double jointed, I'll have to look that up for you, but I always thought it was, okay, I'm going to show you guys something, but you can't get all creeped out and make me feel weird. So, right, like this, right? Like is this considered double jointed? Because I'm not sure. Is this double jointed?
No, double, that would just be like extra flexible.
Okay, so double jointed are people that can do... Class is canceled. All right, all right. And that's so, all right, so this one, that would be like if you go down this one.
If someone were to try to have their arm like this, you would see their elbow.
Okay. You know, I'm going to be honest. That's my homework to look that up for you because I don't know. I don't understand double joint. Does that mean you have double the collateral ligaments or?
You don't, it's not double jointed, that you're like, they're extra flexible, but it looks.
No, but I've seen some people do, like even my brother has the ability, this weird ability to bring this one and actually make it touch all the way back here. Yeah, see, like that. Like I can't do that. And then so I don't know where that, my homework is to find that out for all of you because I'm curious now. I actually don't know why that is. Right. And I'm surprised that I never actually looked it up. But yeah, you're right. I've seen that, and I have no idea what it actually means, and I'll have to look that up for you. Double joint type. Good question. Now, the last few terms. Now, abduction. Now, the tough part is abduction. What you want to write to yourself, the only note you really need here is flexion versus abduction. Oops, with a D. All right. Because they look almost alike, right? If we think about this portion here, right, this was flexion going upwards, flexion, 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 flexion. And then there's a difference between that and abduction. Abduction is the jumping jack, the top part of the jumping jack, abduction, and then coming down, adduction. That's the difference. If it's like this, flexion and extension. If it's like this, abduction with a B and a D. The best way to remember is to rely on the B and the D. Alphabetical order, B goes upwards, like B is higher than D. So that's how I always done it. Or I heard Dr. Meyer teaches her students like adduction, like it's like adding it. So when you bring it to your body, it's like adding it to your body, which I also thought was a really nice way of remembering it. So if you do the top part of a jumping jack, it's abduction. And when you come right back down, adduction. The lower limb, same exact thing. If you go outwards, sort of just going towards the top, again, top part of a jumping jack is abduction, bringing it down to its normal position or back to the body, adding it to the mass of the body, adduction. You can do it along your wrist as well. Your wrist can abduct, right? If you do this, abduction, right? This was flexion, extension, but doing this way, going towards your thumb is abduction, going towards your pinky, adduction. Because if I was in anatomical position, abduction is again doing my hands are doing jumping jacks right now, right? They're doing this, and then they go back down, adduction, abduction, adduction. So they're capable of doing those motions. All right. And even your fingers as well, right? If you did jumping jacks with your fingers, right? Opening them up is abduction when they start their jumping jack, and then bringing them back to normal is going to be adduction. So you just want to practice with these terms at home. And again, the wrist, the same thing. Another one is that we saw our radius and our ulna, right? We learned about them in the tibia and the fibula. They have a relationship that there are two bones, and they allow some rotation around them. So when you're rotating, right, if you're in anatomical position, you are supinated. And so when you go into anatomical position, you are supinating. Or that's supination. If you're flipping something around, like you're flipping a pancake, flipping a tortilla, it's going to be pronation. Pronation. Supination, pronation. Flipping a tortilla or a pancake. And that's what this one is trying to imply here. Rotation. If I told you to do lateral flexion, what would that look like? Lateral flexion to your left, what would that look like? Right, like this. And so rotation is your ability to turn left and right. So you can see a clear difference. If I told you to rotate left, that's like this. If I told you to do lateral flexion to your left, it's like this. Right, so that's the difference between the two. Is that rotation is just shifting from one end to the other, like on a swivel. On a swivel. And then lateral rotation and medial rotation, sometimes referred to as external and internal. And so this one, when you think about this, when you go in for a hug and you're going to hug someone, medial rotation. It tends to be like this, but it's the same motion if you do this. It's the same thing, even if it's like this, it's sort of the same thing. So I like everyone to just normally learn it like this. So when you go on a hug, medial rotation going towards your midline, medial, and then when you're going outwards, lateral rotation. And so that's what those motions are. So these are all movements around joints.
Professor,
Ask away.
when you get tested on this, are you going to show us a picture of the motion?
More than likely, yes. And also, I might describe, maybe I'll say someone is doing a jumping jack, or like I'll have a little figure and he's like at the top of his jumping jack. What was the motion he carried out from anatomical position? And I'll think of some creative questions for that. Like typically, I like using pictures for those kind of things. Yes. And so opposition, this one's a little bit, you're not really going to see this one being utilized a lot in our lab, but it's important to know. Opposition is when your thumb touches your pinky, right? The opposite sides are touching. Opposition, opposition. Depression and elevation, really easy to learn. The one that we're going to learn about next week is our mandible connected to the skull. And so when we chew, right, when we go up to chew, that's going to be elevation, and depression is when it comes down. So it's like the same thing as saying up and down. You can do elevation and depression of your scapula, elevation, and then depression, right? So that's kind of how we're going to be using our terms there. Inversion and eversion. Now, if you look at put your feet like straight on, straight forward, and then inversion is when your toes, make your big toes, your hallexes, make them kiss, right? Make them touch. That's inversion. And eversion is when they don't like each other anymore and they evade each other, evert, right? Eversion. And so that means to go outwards. And so when they go towards each other, like again, big toes, like just come in for like a little tap, that's inversion. Eversion is the opposite. And then another one that we can find on a few joints is protraction and retraction. When we think about protraction, that's when the jaw is going out in that direction, retraction in this direction, and you can even do it with your scapula again, like scapula has elevation and depression, just like the mandible does, depression and elevation. And so when you say protract or retract, that's when you see like this is like going to be protraction and then retraction. And so those are those two motions. So you'll see it, the scapular muscles, when we get to that in like 4 weeks, 5 weeks from now, you're going to see these words come back, so we learned them early on, and movements around the joints.